Good morning. Your healthcare is on fire. That's what we're going to be talking about today. And I say that because, man, this last week, a lot of stuff in the news, a lot of posts, a lot of comments, a lot of engagement. And I can tell you right now that the topic of healthcare has probably never been more on fire. It's a fifth of our GDP as an economy. There's companies left and right that are getting slammed, probably for good reason. Maybe some of them aren't. And just a lot of things going on. So, with all the things going on in the world today, what I wanted to highlight was something that I think is really awesome, and it was a professional dialogue. I made a post the other day. Everybody hates Medicare Advantage. Didn't really think too much of it, only because I had seen so many articles slamming Medicare Advantage, the upcoding and all these different things. Now, I'm biased. I've worked in managed care for almost 20 years, right? And I've been very fortunate to work in some really, really good systems with really good IPAs, really good contract negotiation, really good doctors. And so I'm, one, biased from working in the industry, but two, I've been very insulated from some of the nuance that happens out in other aspects. I also work in California. The regulatory system and environment in California is much different than it is the rest of the country. And we've had to deal with the Department of Managed Healthcare for the last 30 years and a lot of, really odd nuances that are sometimes quite a bit different than the rest of the country. So my perspective is skewed. Nonetheless, what I wanted to do was kind of review that post, and not just what I said in the post, but I really want to highlight to y'all what dialogue means in my eyes, and how there's some very good engagement in this context online on LinkedIn, where maybe on some other platforms we see just a lot of hate going around. There's a lot of nuance, there's back and forth, and ultimately what I'd like to do is bring a few of these folks on and have a dialogue, even virtually, right? A lot of these folks live across the country. We're connected on LinkedIn, but I don't know them personally, and so I think it presents as a really good opportunity for us to leverage the power of the internet, leverage the power of the digital systems that we now have, and have conversations and propose thesis and propose solutions, beat it up, and be able to carry that then into our professional work and the framework and try to deliver some of these things that we think will, either decrease cost, increase access, care, delivery models, all of those things. And so here we go. Let me jump over to my post here. I'm going to add it to the stage. Now, it was a couple of days ago, so I kind of have to scroll through and take a look, but here it is. Everyone hates Medicare Advantage. And this was the post that I was looking at. Now, if we expand it here, I go on to talk about until you look at the actual data, right? And my point here is oftentimes Medicare Advantage gets slammed because of what's considered in many aspects as upcoding. Folks in the Medicare Advantage business and system might consider that just accurate coding. But nonetheless, I go on to kind of highlight, health plans are just printing money. Maybe that's true for some of them, but yet they have the 15% MLR rule, and some dialogue down in the comments has highlighted maybe that's not true. They kind of hide some things under different business structures, et cetera. Fair points. Care is worse. Some folks have highlighted the fact that not all doctors are in Medicare Advantage, and so there's kind of a less offering in some parts of the country. Go on to talk about supplements are better, and then I kind of highlight some of the parts of Medicare Advantage not being perfect. Now, this is what I really, really wanted to get to. Some of the comments in here, and it starts right here. Scott Jacobson, shout out to you, as well as Mark Gentry. These guys have had a very professional dialogue in the chat box here. And both, you can tell, are, very astute at what they've done and what they've contributed to the healthcare delivery system. They both have strong opinions. I think both presented good for and against arguments for Medicare Advantage and or fee-for-service. There's no shortfall on either side of those. But I think these two guys really did a good job. And you can see here, they kind of just went back and forth. And actually, let me load some more of these comments so we can really see the dialogue. But right here, they kind of get going and talk about, Scott highlights his, experience in healthcare, and really saying no one believes that this 85% of premium rule goes directly to patients or patient care, right? Mark kind of comes back and says, no, not true, and kind of highlights some things. What I'm going to do is actually invite these guys on, and I said it in a comment to them, say, hey guys, this is great. Like, I love this dialogue, even though they disagreed on some things. Let's get on together and let's kind of have a chat through this, right? And healthcare is nuanced. Medicare Advantage is one aspect of healthcare. It encompasses the entire delivery system, but it's just one aspect, one way of delivering things. It involves some private companies, health insurance companies, that many of whom are getting slammed in the media, maybe for good reason. But nonetheless, shout out to these two guys. I also pulled in Sharath Pinkenti from Bloom. And, Sharath he's, got his PhD in data science and, works for a company that's in the weeds on this stuff. And so one of my thoughts has always been Medicare Advantage is designed ideally to beat the Medicare fee for service benchmarks from a cost standpoint. That doesn't mean that it always delivers on the care standpoint. And what care means could be different things, could be access to care, could be quality of care, could be a care delivery model. And all those things, although similar, are very different. Access to care could be different in a rural market than access to care in a high densely populated market. Getting to the doctor, what does that mean? Medicare Advantage oftentimes creates opportunity with supplemental benefits. If you look at some of the health plans and the way that they've designed these things, they offer ride shares, Uber, Lyft, et cetera, access, because for the Medicare Advantage plans, they're really incentivized to have a high quality of outcome. They have to manage a flat dollar, except for when they have some of these coding nuance, which documents how accurate, if you will, an accurate documentation, of a patient's acuity. And that can help get a higher reimbursement because the federal government acknowledges that it takes a little bit more time, effort, and resources to care for patients who are sicker, if you will. Kind of a short version, but would love to have these guys on to kind of talk through it and just real proud, in a day and age where so many people are down and doom and gloom on the United States and healthcare and, kind of woe is us mentality. I thought these folks did a really good job of coming in with dialogue, with coming in with an argument, with a stance, and being able to present something and have that nuance. So really excited to have them on in a couple of weeks here. I'll reach out to them and see if we can't just do it kind of live, free form, open conversation, have the dialogue and see where we can go from there. Okay. So the other part of what I wanted to do today was kind of talk through a case study of an independent physician practice that we manage in Northern California. And it highlights two things. One, I don't think there's ever been a better time to be an independently practicing PCP specifically. And I say that because PCPs oftentimes have a different incentive model in managed care than specialists do. I also still think it's a great time to be a specialist in the independent space, but many, many doctors over the past, several decades have started to migrate towards that, foundation model or integrated practice model where they're more of an employee. They come in, they can perform their work. There's still high expectation. The care, the quality, the setting is oftentimes improved, if you will, because within these big systems, they can borrow money, whether that's from bonds, whether that's private equity, whether that's, investors that, individually and independently come in. But with all the access to technology, including artificial intelligence, including different EMRs that are more cost efficient than they were 10 or even 20 years ago, I think there's never been a better time. In our market, specifically in the Northern California, Sacramento market, we've had in the last 6 to 8 months, probably 10 primary care physicians join us as independent practices from a large group. They're leaving the employed model after decade, 15 years of practice and starting their own practice because they want some more of that entrepreneurial freedom, the flexibility, the practice management. It's harder. You got to get your own lease. You got to get all of your own staff. You got to manage HR. You got to manage, the schedule, the calendar, all those things, which can be challenging. But now with a lot of the AI tools, it's becoming easier and easier and easier. And to be able to market yourself is, direct to consumer, like what I'm doing here, right? We're directly to the consumer, where in years past, it was expensive TV, radio, billboard, et cetera. Maybe you needed a group to go out and help you market. And now PCPs and physicians in general can hop on a camera, document the day in the life, talk about what they do, their specialty, how they operate, the type of practice they have, the nuance that they like to do, and get right to the patient and draw them in. So never been a better time. And at the same time, there is so much nuance in healthcare that I think if independent physicians and practices don't understand some of the nuance, they need to get educated. And that's a part of what I do in my day-to-day job, is just to help folks understand if they're in the managed care space, which is what we do, right? We manage independently practicing physicians, both PCP, the full gamut of specialty. We do the contracts with the health plans. We go downstream and get facility and ancillary and hospital contracts, et cetera. And ideally bring that network, to plans and to the doctors so that they have the opportunity to not only earn in the fee-for-service lane with PPOs and fee-for-service Medicare and Medi-Cal, where I'm at, and or Medicaid elsewhere, but we create the opportunity to help them earn in the at-risk business, in the managed care business, and in the ACO or accountable care organizations, shared savings, et cetera. And by providing quality instead of quantity of visits, these physicians can often make more, have more support from their management system office, the MSO, and or the IPA if it's in-house. And so the case study here today is a small practice, a lot of nurse practitioners, and they've had some changes in their contractual relationships with other independent physician associations, other IPAs. And there's also been a lot of shift in the market last fall during AEP, annual enrollment period, where a large health plan had a dual special needs plan that they pulled out of the market. Probably wasn't very profitable. Dual special needs plans that aren't well managed can cost a health plan a lot of money. And this practice had a couple of hundred members with this dual special needs plan. Now, we got ahead of it. We educated them. We educated physicians in the market. We had other health plans that have a similar offering, although in California, these other health plans didn't have a contract to do what's called a dual special needs plan or even a lookalike. They had a product offering that looked like, even though it wasn't a lookalike plan, looked just like the dual special needs plan, meaning generally speaking, dual special needs plans have a zero premium, and then they call them zeros across the board when it comes to copay. PCP copay, zero. Specialty copay, zero. Hospital copay, et cetera, et cetera, et cetera, right? It's a product designed for somebody who has low income, if you will, as determined by the standards of your state, as well as probably some type of a diagnosis or otherwise criteria qualifying as a special needs plan. It could be a chronic special needs plan. In this instance, it's a dual special needs plan. So folks are generally on Medicaid, if you will, and or Medicare. So Medi-Cal in California, Medicare, they have dual, right? They're both on the government subsidies. Nonetheless, the term kind of pulled the carpet out of underneath this practice. And so now in the beginning of the year, they're looking at their capitation checks and saying, hey, what's going on? Why did we all of a sudden decrease our revenue when we thought we were growing in membership? And although they had new enrollment with us through a different health plan, because the plan that termed the dual special needs plan, these members started going to other IPAs that they're contracted with. So what it was really a shuffling of the deck for them internally for one source of income from one IPA to another, but not quite understanding it. The second part to this was as we started getting in deep, I don't know what their contracts look like with other IPAs. Our approach has been the last couple of years to redesign our PCP platform such that it's a value-based plan. We're trying to get rid of a lot of things from the fee-for-service standpoint that don't make sense, don't offer value either for the doctor or for the patient, but get them on a risk-adjusted fee schedule. So as their risk adjustment factor, the RAF, the level of acuity, if you will, that as Medicare designed it, says that a patient is sicker and needs more care, the monthly capitation goes up. So the higher the RAF, if you will, the higher the reimbursement, and they get kind of the full suite of services that the MSO offers. So we also help them with the HEDIS measures. If you're not familiar with those, it's the quality measures that breast cancer screening, colorectal screening, blood pressure, diabetic A1C, et cetera, et cetera. And some patients are, qualify for most of those, some don't. But the management system does outreach, does the contracts with the imaging centers and or the labs, et cetera, to try to get these patients in. So the doctors can focus on, the day-to-day patient care. We can help with kind of the supplemental avenue. Now, they weren't aware of this part of their contract. And so I say that because as high as their, RAF could go, if you will, they'd get a higher reimbursement, but they didn't have it in their contract with their billing company to send claims in for their HMO managed care patients, meaning the data that tells the management system that we then send to the health plan, that the health plan then sends to Medicare, what we weren't getting. So all the work that the provider was doing, the billing company only gets reimbursed a percentage of billings. And because managed care billing doesn't get reimbursed on a transaction line item like it does in fee for service, the doctor was missing out on all of the RAF money, if you will. And I say RAF money collectively because it's not paid as RAF money. It's a part of the design, generally speaking, to help these doctors get a reimbursement that's stable. But the billing company and the contract between the billing company and the primary care practice wasn't such that it incentivized the billing company. So we had to talk with them a bit about, hey, like maybe there's some opportunity to restructure the design of your contract. You have 3 or 4 IPAs that you're contracted with. I would imagine you're going to be in the same boat with all of those. So aside from members moving and the shuffling of the deck there, you're probably losing, I would imagine, hundreds of thousands of dollars a year collectively because the claims aren't being billed, only the fee for service stuff. So only their pure Medicare, pure Medi-Cal, and any PPO business that they have. So this is what I spend a lot of my time with, is just educating doctors on what their contract looks like. And then what does the back office look like? Because the claim submission, the referral process, the eligibility, all these things have a big impact on independent practices. And it looks like we have somebody join us. Thank you for hopping on. Happy Friday if you're here with us. And it looks like I think you're on maybe with Facebook. So I can't see who it is, but if you want, drop a comment. Let me know if you have any questions. Happy to answer any questions. We're talking a little bit about your healthcare on fire, and then I've gone into a little bit of nuance as it pertains to managed care and in the Medicare space. So nonetheless, never been a better time, in my opinion, to be an independently practicing physician, yet you need to understand the nuance. And once these physicians understand the nuance, it is rolling, right? The snowball is picking up steam as it goes downhill. And we have some practices that are really, really thriving because they understand this model. I also am excited. Me and Sharath, we spoke about Sharath a little bit earlier, Sharath Pankanti, we're going to model a bit of the cost savings. So, MedPAC and some of these other folks have done articles. Well, hey, the upcoding in Medicare Advantage is really leading to this increased multi-billion-dollar, spend that we don't have. In my head, I'm like, yeah, it's very easy to calculate costs up front when there's a dollar attached to it. But how about all of the avoided hospital admissions? Where do we account for that, right? How can we model for every managed care member that gets their annual wellness visit done, that gets their breast cancer screening, their colorectal fit kit, they have a team, blood pressure monitoring them from remote, and all these different systems that we have that are designed to keep the patients out of the hospital. For every dollar we spend on preventative care, what do we avoid in hospital admit, right? It's got to be huge. And so I'm not sure that some of these articles and the way that they're framing the upcoding and the cost associated are taking into account the full picture. Taking in the front end, which is the coding, the treatment side up front in the outpatient setting, but not necessarily the cost savings on the back end. The other part of that is unlinked chart reviews. So CMS announced that they're no longer going to permit unlinked chart reviews to be accepted. I actually think that's a good thing. We've been practicing for a long time. There's a lot of AI, even before AI was the term, there's a lot of suspect data, meaning if a patient has kind of a digital footprint of their care, could be a pharmacy, could be a lab, could be a doctor, could be, out of state, could be out of the country. If some of that information trickles back into Medicare, the health plan, the IPA, the MSO, it paints a picture and go, we don't see in your chart that you've been documented for diabetic retinopathy, if you will. But we did see this one thing, and we're going to give that piece of information to the doctor, ask the doctor to have an annual wellness visit. And during the annual wellness visit, ask the doctor just to, bring it up in conversation and say, hey, this happened. What was going on here? Oh, I was seen by this doctor over there and X, Y, or Z happened. And then the doctor that's treating them at the time has the opportunity to kind of do the full review, an exam, and then come up with their own determination and diagnosis. I don't think that's a bad thing, but, automatically submitting some of that data into CMS without having it reviewed is obviously what CMS is cracking down on. I think that's a great thing to do. It's going to just put a little bit more pressure on some of the teams and systems that haven't built the rapport. And I'll tell you, from doing the outreach and trying to get folks to understand the IPA versus the doctor versus the MSO versus the health plan versus CMS can be challenging. Many times folks are auto-enrolled in these Medicare Advantage plans. Maybe they called a hotline. Maybe they saw an ad on TV and weren't quite sure. And all of a sudden they're in this plan and they don't even understand. So we spent a lot of time just helping to educate our members. But really and truly, I think a great day and age. It's not doom and gloom. The future looks bright, as Patrick Bet-David would say. But thank you guys for joining. Those of you who did, if you have any thoughts, comments, feel free to post them below, post them on the platform you see this as it's repurposed. Happy to engage. And I look forward to having a chat with Scott Jacobson and Mark Gentry. Thanks again, you guys. Really, really professional job, and can't wait to have the dialogue a bit further. Hope you all have a great day. Bye-bye.